Good evening, all. At the outset, I want to thank the organizers for the opportunity. So I'll be following the session on immunotherapy. As we have heard from the previous speakers, immunotherapy is a wonder drug. Immunotherapy is good even in patients with poor performance status. But we have other wonder drugs. Those are the TKIs. Immune checkpoint blockade with PD-L1 has revolutionized the treatment of NSCLC. The other wonder drugs have also dramatically improved patient outcomes, and there's an expanding list of potentially actionable alterations and targeted therapies. As of 2022, these are the various targeted drugs, targeted agents that are available with us. But are these two drugs, can these two drugs be used together? Can a patient have a piece of both pies? So what data do we have in front of us? The current evidence for the use of immunotherapy in actionable driver mutations comes from subgroup analysis. It comes from phase 1, phase 2 non-controlled trials. The level of evidence of use of IO in NSCLC with driver mutations is low. The largest data is the registry, that is the immunotarget registry. The immunotarget is a database of more than 500 populations with KRAS, EGFR, ALK, BRAF, ROS. It has followed the retrospective pattern of survival of these patients. But a single genetic alterations predicts lack of efficacy of immune checkpoint inhibitors. This is setting the table for the discussion today. We look at the EGFR mutation status, the flow. EGFR positive associated with an inferior outcome to this medicine. This chart compares nivolumab to docetaxel, which I'll be discussing this later too. These are the retrospective analysis. EGFR or ALK positive have a response rate of 3.6%. EGFR wild type or ALK negative have a response rate of 20%. Also smokers, heavy smokers have a response rate of around 20%. This is immunotherapy responses. Light smokers have a response rate of 4.2%. These are the response rates on the immunoregistry trials. EGFR, immune checkpoint inhibitors response rate of 11%. ALK, immune checkpoint response rate of 4%. ROS, 14%. This is showing a higher response rate because the number of patients in ROS1 was less. This is again the response rates for the immunotarget registry. Now, when we look for immunotherapy, when we are using immunotherapy in NSCLC, the thing that we use, the thing that we check for is always the PD-L1 expression. But Prabhat has explained that is PD-L1 or TMB or MSI the go-to marker for us in NSCLC. So in non-driver mutation patients, and PD-L1 expression is a continuous variable from 0, 1, less than 50, more than 50, and it can be used as a predictive marker for immunotherapy. But according to the authors of this paper, in driver mutated patients, PD-L1 expressions may represent a constitutive activation and may not be a marker of adaptive immune response. So we need to look for things other than the PD-L1 expression. Now looking at the data, other than the retrospective analysis, do we have anything prospective? What are the things that we can do to target EGFR, ALK, ROS with immunotherapy? So the combinations that we have are ICI monotherapy, an immune checkpoint inhibitor with a TKI, or immune checkpoint inhibitor with chemotherapy. Now these are data for EGFR. This is a meta-analysis for the use of drugs pembro, atezolizumab, and nivolumab. There is a clear-cut loss of benefit in EGFR mutated patients. The other options that we have, coming to option number 3, ICI plus chemotherapy. So the best possible data that we have is Empower 150. Wild type, definitely there is a good response. But coming to the subgroup analysis, also there is separation of curves. The hazard ratio for both PFS and OS cross unity. So there is no difference in OS or PFS for patients treated with chemo, bev, or chemo atezo in EGFR patients. 75% had exon 19 del or LD858R mutations. So we are looking at data for monotherapy. EGFR, it doesn't work. We look for data with chemotherapy and immune checkpoint inhibitor, doesn't work. What about TKIs plus immunotherapy? Two major issues with them. First is hyperprogression, and the second is enhanced toxicity. This enhanced toxicity is not only across, not only with EGFR, but it is also with ALK. The toxicity most commonly seen is ILD and hepatotoxicity. But are all EGFR mutations the same? Just like we have PDL1, we might not, that might not be the best predictive marker. Are all EGFR mutations the same? So this data shows that maybe exon L858R might be a better predictor, might have better response to immune checkpoint inhibitors than deletion 19. The reason for this is not indicated in this paper. Is ALK any different? We have the phase 2 Atlantic trial with durvalumab. There is no response in the 15 ALK positive patients treated with durva. The PFS was less than 2. The immunotarget registry, retrospective analysis, 23 ALK positive patients, no response. And there was a higher incidence of hepatotoxicity with the use of ALK inhibitors. Is ROS any different? The higher percentage of positive response with ROS because of the less number of patients, but only 1 out of 7 showed response. Why do cancers with oncogenic alterations respond poorly to single agent ICI? Mostly they are never smokers. They have a low PDL1 index. They have a low TMB and an immune cold environment. That is one of the reasons why immune checkpoint inhibitors might not be the best drug for patients with driver mutations. Is there anything else? We have discussed EGFR, ALK, ROS. Is there any other mutation? We have KRAS, BRAF, V600E and MET. So KRAS, which is a common mutation, is commoner than EGFR in some populations. Does it have a better response as compared to other driver mutations? Yes, KRAS does have a better response to ICI as compared to other driver mutations. But that comes with the caveat that KRAS is not one mutation. There are STK11, there is LKB1 mutations that are there which don't have good response to anti-PDL1 and anti-PDL1 therapies. So in the take-home message for today is, although there are retrospective analysis, we have prospective data which suggests that immune checkpoint inhibitors might still not be the best therapy and the best agent for a patient with driver oncogenes. We need to look beyond PDL1 therapies, PDL1 as a marker for determining the immune checkpoint inhibitors. Although KRAS predicts response to therapies, KRAS is not one mutation. We have subset analysis from Empower 150 that has shown that even addition of chemo or a target agents might not be the best agent. We have TKIs and ICI combination that have shown increased toxicity. So the effort now need to be focused on new immunotherapy approaches, especially the ones that we have shown benefit. That is a Pacific trial with durvalumab that could help us extend to patients with driver oncogenes. We have data with neoadjuvant, adjuvant therapies that are there with immunotherapy. So these might give us an idea if immune checkpoint inhibitors might be useful in the future in patients with driver oncogenes. Thank you.